It starts out with a couple of twinges in your stomach, maybe a little nausea, maybe some sharp pains. And then before you know it, you are running to the closest toilet with which you become very, very familiar. Cyclospora causes frequent watery diarrhea with sometimes explosive bowel movements, but is typically a relatively rare cause of infectious diarrhea. However, the US is in the midst of one of the largest documented cyclosporiasis outbreaks. How does one acquire this parasite? What are the risks? And more importantly for this audience, how in the lab do we approach diagnosis? Well, let's find out on today's episode of Editors in Conversation. I'm JCM Editor-in-Chief Romney Humphreys. This episode of Editors in Conversation is brought to you by the Journal of Clinical Microbiology, available at asm.org/JCM. Editors in Conversation is supported by the ASM, which publishes JCM. If you're a member, you can get up to 50% off publication fees when you publish in JCM or any of the ASM journals. So today I am joined by not one, but two of our editors and a member of our editorial board to discuss the current Cyclospora outbreak. Dr. Dan Rhodes is an editor for JCM and an associate professor at Cleveland Clinic. Dan is my co-host today. Hey, Dan, welcome.
Hey, thanks for having me.
Happy to have you. We're also joined by two extraordinary parasitologists, Dr. Bobby Pritt, who is an editor for JCM and a professor at Mayo Clinic in Rochester, as well as Dr. Mark Couturier, director of microbiology at Maine Health NorDX and professor of medicine at Tufts. Welcome to both of you to Editors in Conversation.
Thanks for having us.
Yeah, thanks so much.
Awesome. So, Dan, let's start with you. The idea of this podcast topic came following an email where you sent me, saying this is like a big deal and what at JCM are we going to do about it, which is why this podcast came to be. So what are you seeing at your institution?
Yeah, thanks, Romney. It's kind of wild. It went from 0 to 100 very quickly. Cyclospora testing's a sleepy little item on our test menu. We get maybe a couple a day, maybe a handful, picks up a little bit in the summertime. But we don't get more than a few positives a year usually. Everything changed a couple weeks ago, and now we're getting hundreds of samples a day, 50 positives a day. And I'm not sure, we're really right in the middle of it. I don't know when it's going to peak. So it's still a big deal, and I'm concerned it's becoming an increasingly big deal.
Yeah, those numbers are like incredible to me. Bobby, I know you guys at Mayo are doing a lot of testing as well. What are your numbers like?
Yeah, it's crazy here. Mayo Clinic Laboratories is a large reference laboratory. We get specimens from all 50 states. So all of the hotspot endemic areas we are seeing specimens come in from. And, normally in the summertime, we get up to maybe 60 or 70 specimens a month. But we are now over 6,000 specimens just for July.
Wow.
And it's crazy. We have all hands on deck. We are pulling people in from all over. It's almost like COVID, although fingers crossed, not like COVID. But it's one of those situations where we're pulling in all sorts of people to have them processing stool and make slides.
Yeah, all hands on deck. Yeah. Mm-hmm. And Mark, we've only seen a small number of cases here. I assume, is it similar for you, or what are you guys seeing?
Yeah, and our situation's pretty unique too. So we are the largest healthcare system in Maine. We cover mid-coast, central Maine, and parts of central New Hampshire. We have seen a massive uptick in O&P volumes and send-outs to Bobby's lab for staining. Our screens for Cyclospora, which we do, kind of as on suspicion, we've not seen a single positive yet. So,
yeah. It's just these outbreaks are so regional. It's really interesting to hear this like tale of 4 labs and how different the experiences are. So one thing that's been really interesting and kind of incredible to read is the lay press's descriptions, which I think is maybe why we're seeing such a demand for testing right now. Some of the descriptions I saw last night, gut churning, One person described it as humiliating. My personal favorite, I read an article in Business Insider of a personal account where he named it Summer 2026 Enemy Parasite Number One, which I didn't realize there was a ranking system for enemy parasites. Maybe Bobby, Mark, you guys are aware of this system, but I didn't hear about it. But outside of what we're hearing in the news, maybe we can take a little more clinical kind of slant on this. What exactly is Cyclospora? What is the spectrum of symptoms? Bobby?
Yeah, sure. So Cyclospora, I'm sure most of the listeners know, it's a parasite. It's a apicomplexan parasite, small, microscopic. You can't see it with the naked eye, and it gets into soil or water through fecal contamination, and then can contaminate a whole host of produce, fresh fruits and vegetables. And then, of course, if those are ingested, then people get infected and they can have pretty severe symptoms. So I don't know if I would call it parasite enemy number one, but gut churning is not a bad description. So about 1 week after acquiring the parasites, between say 2 to 14 days, people present with profuse watery diarrhea, which has been described as explosive. They also get nausea, painful abdominal cramps, bloating, increased gas, loss of appetite. And then if the illness goes on, which it can if it's not treated, they can have significant weight loss, sometimes low-grade fever and vomiting, although those are less common. And if it's not treated, it can last for weeks or months and even recur.
Wow. Yeah, that's incredible. And Mark, I feel like maybe, I don't know, a long time ago, 20 years ago or something like that, you schooled me on how we do the diagnosis for this parasite. So maybe you could share with our listeners, like what in the lab do we do for diagnosis?
Sure. And I think in my region, the BZO would challenge whether number one is really Cyclospora. But so, if we go to conventional methods, the modified acid fast stain and the modified cephalin stain have long been our quote-unquote coccidia stains for detecting Cyclospora and Cystoisospora. That staining is not performed in every clinical laboratory. It's a little bit specialized. More recently, adoption of multiplex PCR panels has really expanded the breadth of Cyclospora testing. There's at least 3 FDA cleared tests available to detect Cyclospora in multiplex. And that's really been instrumental in the outbreaks we've detected in the US since 2013, since the early clinical trials actually revealed that we probably undertest and underdetect this pathogen. And then kind of a more recent carve out is the use of AI to augment some of our classical, not optimal techniques, such as the ONP. So we generally say the ONP is not meant to be used for detecting Cyclospora. It doesn't mean you can't, but it's a lot more difficult to detect. It shows up as a clear sphere. It's very nondescript. But AI can actually see through that level of non-staining and nondescript features. And then a final method, which is a good screening tool for labs that can do it, is UV autofluorescence, which is just using broad range filters, similar to use for like a calcium white stain, and actually just screening stool to look for autofluorescent 8 to 10 micron oocysts.
Mark, I have a follow-up question on that. You said that you're getting a lot of ONPs, even though you're not seeing any Cyclospora. How can we help people looking for lab answers? How can we point them in the right direction? Because I always find it confusing when I'm teaching to say, here's our ovum parasite exam, but you have to know what parasites you care about because our routine ovum parasite exam doesn't test for all the parasites. And a lot of people don't think about, which parasite. Any tips or tricks to help us point people in the right direction?
Yeah, it's really difficult. We try to use in our test directory ordering comments that are built into the order and footnotes that will specifically say, first suspicion of cryptosporidium, also order antigen. For coccidia, consider acid fast in our case, we send it to Bobby, so modified saffron. And then our lab also, if we see something suspicious, we don't advertise that we do it, but we do a UV in the background. And then if we think it's suspicious, we'll actually contact the provider and say, we're going to result it as presumptive Cyclospora cystospora, and then we'll send that specifically to Bobby to try to make it a higher yield strain at that point.
Thanks. Well, maybe it's reassuring to hear that we're all trying the best we can. So I think we're all, as we mentioned, experiencing this outbreak a little differently. Romney and Mark, your geographic area is not really seeing many cases. Bobby, like you said, you're at a reference lab, so I'm sure many labs are relying on you for your testing support. Our lab is in the outbreak region, apparently, because we're seeing a lot of positives locally. I'm curious about the different experiences at each of our labs. Maybe, I don't know, Romney, you want to go first?
Sure. Yeah. I'd say our biggest concern right now is kind of like the worried well. So we're getting a lot of folks coming in with maybe, norovirus or something like that are really insistent that they need to be tested. So what we've focused on more is education of our clinicians and making sure that they're, looking for the more common causes, because we really have not seen many cases for us. Risk factors include travel to Mexico, interestingly enough, and then also to Michigan are the two that we've really identified. But again, I think in the entire state of Tennessee, there's been 20 cases. So it's really low for us. And it's really helping people to find the right test. I will say almost everyone wanted to order an O&P to help with this. And so we had to direct them to another test. And they're like, well, this test says cryptosporidium. I'm like, and, you got to read the whole test name. But it is really confusing for folks. They're not used to dealing with this. They're not used to testing for it by any means. So that's been mostly an education story.
How about you, Bobby?
It's interesting. We serve two different populations. Our local Rochester, Minnesota population, where we actually don't have really that many cases. Actually, the most recent positive we had of a cyclospora case in Minnesota over the past several weeks was just a traveler to Mexico. So locally, we are telling people to follow our routine test ordering algorithm for infectious causes of diarrhea and community acquired diarrhea, which for us is a multiplex pathogens panel and maybe an ova and parasite exam if they've traveled. But for the rest of the country, especially the areas where there are big outbreaks and where we're getting a lot of specimens, those are coming in from the highly endemic areas, or at least the areas where they're seeing these outbreaks. And for them, we're really saying order our test, which we call specifically Cyclospora. We use a modified saffron stain, which is like a modified acid fast stain. It turns the oocysts red. It can detect cryptosporidium and cystoisospora, but we don't really recommend, for cryptosporidium, we, like Mark, we say use the antigen test. So actually it was really in our benefit, or to our benefit, that we have a test that's called Cyclospora. So people know to order that test. Our ova and parasite volumes are also up, but not to the extent of our Cyclospora volumes. I'll just mention this here. It's probably as good of a time as any. We're getting to the point where people are running out of things. They're running out of fixatives. They're running out of the 2-vial Parapacks, the EcoFix, Total Fix. I'm starting to hear people saying that they're having a hard time getting those. I don't know if any of the GI multiplex cartridges are getting short on supply, but this is definitely getting to a point where we're actually now telling people if they can get the specimens to us fresh, we'll accept fresh stool up to 3 days, or they could even make their own formalin concentration and put the stool in formalin.
Interesting.
Mm-hmm.
How about you, Mark?
Yeah, we're dealing a lot with the worried well. We've had a couple return travelers from states that are affected. They've been negative, but we're really trying to reiterate through messaging and Epic, through our intranet communications, as well as our test directory, to keep providers informed that not only is the testing horribly manual, horribly time-consuming in its normal state, when you can jump off the bridge with this in a setting where we're not seeing it, you're further delaying and crippling other testing. So our test directory right now actually says like Nordex is currently delayed on OMPs. And then we also put a link to Mayo's notification about cyclospora testing delays. So we're like telling them like, this already exists. Don't make it worse. Please think about what you're doing. Consider pretest probabilities. Consider relative prevalence of other pathogens. We got like massive Campylobacter cluster this week. So a lot of the providers that have reached out and been like, I think this patient has cyclo, and like, could they consider Campylobacter? Because we've had 12 today. So, it's just kind of doing our part to be good stewards and good educators and good team members to just let our providers know. Yes, it's in the news. Yes, it's widespread amongst other states, but it's probably not going to be that high yield here. So let's try to keep it in perspective.
Not going to lie, Mark, I'm a little jealous. Right now.
Well, okay. So I'm going to share how I've spent my last 3 days lunch breaks reading UV screens. So don't get too jealous.
Yeah, we definitely are right in the middle of things here. Similar to what you're saying, Mark, and Romney, trying to keep people from ordering other tests that aren't appropriate. We've seen an increase in C. difficile testing, and the full microscopic OMPs, and even routine, bacterial PCRs, which I think is appropriate because, like you said, Mark, Campylobacter's around. It's the summer, Salmonella's around. So that's not necessarily wrong, but, a lot of this is Cyclospora. Like you were saying, Bobby, I'm worried about supply chain. We have not experienced real supply chain issues yet, but all that PTSD from COVID's kicking in, and it's not a problem until it is a problem. So I'm waiting for those shoes to drop. And then we're, it feels like COVID in a lot of ways because it feels like it changes every day. How many are we getting today? How many are we getting tomorrow? Do we need to scale up? Do we need more people? Do we need to try to make the process more efficient? It's kind of wild that all this has happened in just the last 2 weeks. So we'll see what it's like on the other side.
Yeah, totally. So, Mark mentioned something about keeping your differential diagnosis in mind. And, so Bobby, maybe if I can turn to you, what kind of things should clinicians be thinking about that help, direct them towards this is more likely, or maybe this is less likely, and I don't need to think about primary testing for Cyclospora?
Yeah, that's a great question, Romney. And there are some differences between cyclosporiasis and then say viral pathogens, viral causes of gastroenteritis. So with this ongoing cyclospora outbreak, of course, all the clinicians, maybe they'd have a lower threshold for ordering it. But I think stopping to ask about fresh produce consumption, recent travel, exposure to someone with similar symptoms, and then asking about the length of symptoms. If someone's had watery diarrhea that's been longer than you would expect for, say, a viral illness, that's been going on for days, even weeks, or maybe has looks like it's getting better and then comes back, those would be some clinical signs and symptoms that would point a clinician towards this being potentially cyclospora. I should say that cryptosporidiosis and maybe giardiasis can also have similar symptoms, but in general, those protozoan parasites would have a longer amount of symptoms, and people would be sick for a longer period of time.
I keep watching public health websites. I keep maybe wrongfully holding my breath, waiting for the epidemiologist to find the smoking gun to put their finger on what the problem is, so that we can stop the exposure. Michigan's reported, I think, about 3,000 cases now. This is a really big foodborne, well, assuming it's foodborne, outbreak. I was looking into whether this could be the biggest foodborne outbreak described. I came across a salmonella outbreak in the 90s linked to ice cream in the U.S. that they estimated impacted 250,000 people. Could this outbreak eclipse that number? Have you heard what's driving it? Do you know? What do you think?
No, I mean, I think at this point we don't know the cause, and I wouldn't hold with bated breath that we will. The challenge with cyclospora is these oocysts have such a complicated, long maturation cycle that involves factors that we don't completely understand in the environment, but it can include UV, temperature, humidity, moisture, and that's just before it gets to the vehicle to get into the human. And then once in the human, there's another delay. So this is really epidemiologically one of the hardest things to actually nail down a vehicle for. Because imagine being asked, what did you eat 16 days ago? Right? Like, it's so hard to know. And I previously did some teaching on this, so I pulled all the epi data from the CDC's website, which is now gone. But thankfully, I've got a PowerPoint that lives in perpetuity. And the largest cyclospora season was 2019, with 2,400 confirmed cases. Now, confirmed versus actualized, right, probably tip of the iceberg. And when I look back at the other years, there's some others pretty close, and then others in the 500 to 1,000 range. Most of them had no identified vehicle. So, it wouldn't be surprising. I had a really interesting conversation with an epidemiologist who, as everyone was talking about, maybe it's cilantro, maybe it's lettuce. And he brought up a great point that I mentioned years ago in a talk. What if it's groundwater? What if humans have contaminated the groundwater if it's being irrigated on all kinds of different crops? Right? So if that's a scenario that ends up playing out, it could be way more complicated than we think.
Mark, as you were describing like this complicated life cycle that involves a lot of environmental factors that are required to mature the parasite such that it is in its infectious form, is it possible that that's just a constellation of conditions that was bad luck for this particular outbreak or past outbreaks? In other words, once this crop of whatever it is consumed, might we see our numbers go back down?
That's entirely possible, yeah. I mean, if there was a mass harvest of something that, for instance, is like a leafy green and the entire field got harvested at once, it could be there's nothing left. And that could all be circulated out into the food supply. And it's just going to be that trickle effect of, time for oocysts to maturate in different, shipments, time for the oocysts to infect and produce symptoms in different patients. So yeah, this could be a prolonged kind of tail, but it may not necessarily mean that it's ongoing point sources.
And maybe, Bobby, I'll ask you, I guess we never really said what exactly causes those oocysts to be in the environment. What is the life cycle?
It's a really good point, Romney. They come from human feces. And so that's why we usually don't see this acquired locally in the United States. It's in areas that maybe don't have the full sanitation systems and access uniformly throughout like we do in most of the United States. So places that grow the produce and then import it into the U.S., those are the places where the contamination likely occurs. Humans that defecate into the areas where crops are being grown or where it gets into the groundwater or irrigation water, which is then used to irrigate fruits and vegetables. That's how it's introduced into the environment. And importantly, those oocysts actually need some time to mature in the environment. So they're not infectious as soon as they're passed. You can't pass this person to person. You actually need the human feces to get into the environment for those oocysts to mature and become infective and then get into the food that is, or the water that's ingested for the whole infectious cycle to continue.
Interesting. All right. Well, so we got a lot of people who are infected. How is it treated? Is it self-limiting? Should all patients get treatment?
Yeah, so unlike many viral causes of gastroenteritis, which will get better on their own, cyclosporiasis often doesn't resolve quickly on its own. And if it's left untreated, symptoms can last for weeks or even months. And what I mentioned previously, a hallmark of the infection is that patients will have recurring or relapsing infection. They'll feel better for a while, and then the diarrhea will come back. So because of that, the CDC does recommend treatment for most patients. And the treatment of choice is an antibiotic, trimethoprim sulfamethoxazole or TMP-sulfa, sometimes under the trade name Bactrim. And usually you take it for 7 to 10 days in immunocompetent adults. And it's very effective. It usually is curative for most patients. Unfortunately, if you have a sulfa allergy, there's not really well-established alternatives. There's some reports on ciprofloxacin, nitazoxanide, but there's also some reports that, it might be efficacious in some patients, but probably isn't effective for most. So in those patients, they may not have a good alternative.
So what you're saying is I need to avoid the lettuce because I am one of those people who's allergic to trim sulfa.
Oh, no. Yeah.
I guess you might weigh the relative allergy versus the treatment. Yeah.
Yes. And I wouldn't necessarily say avoid all the lettuce, but the recommendations out there is to probably avoid bagged lettuce if you are if you're in a state that's experiencing a high outbreak, the local produce may be impacted. It's so hard to know because we don't have a source. But locally grown produce, like from your backyard or the farmer's market, is probably safe because we don't, as we discussed with the life cycle, we don't think we're getting fecal contamination into the soil and water where we're growing vegetables locally.
Got it. Cool. And I guess maybe I'll ask this, Mark, from you, as you guys probably might have been able to anticipate. I'm going to ask about resistance. Has there been documented resistance to trim sulfa with this bug, or what do we know?
Yeah, we don't know a lot, to be honest, when it comes to Cyclospora, but what we do know is that patients treated who have documented infection, treated with an appropriate course of Bactrim, generally recover quite quickly. In fact, many patients will have symptom improvement after just a couple of doses.
Yeah.
There's some data that suggests that the course of treatment isn't completed, or that the patient has severe underlying conditions that you might have to do longer courses. You might have to do adjunct efforts of dietary, alterations to try to just get that post-inflammatory diarrheal symptom to resolve. But we don't have a way of culturing this. So in vitro experiments for susceptibility really don't exist.
I'm glad you asked, Romney. It wouldn't be a conversation without talking about resistance. So
That's right.
I really appreciate you putting this together, Romney, and thank you so much, Bobby and Mark, for coming. I've really enjoyed the conversation, and I hope you stay in the clear down there in Tennessee and in Maine, and we'll keep you posted.
Mark, let's be honest. Do you have a little FOMO right now?
I'm going to say, as much as I hate reading so many UVs, everyone, I'm like, maybe this will be positive, but yeah, that's all right. I've had enough magnesium and plasma in the last couple of weeks to satisfy my urges.
Excellent. All right. Well, as Dan said, thank you guys so much for joining us and talking about this. I know it's a topic that a lot of people are grappling with and have interest in, so we really appreciate your expertise. For the audience, if you've enjoyed this, please subscribe to the podcast, share it with your friends, your colleagues, and thank you for listening to Editors in Conversation. Bye, all.